talk, just as recognition for this occasion. So here's a little plaque.
So I mentioned at the beginning of the day that we are going to be covering a variety of topics. Clearly prevention is tremendously exciting, and I think we've given you a very broad perspective of where things, the amount of information that we've learned and where we're going. We're going to talk now about some very practical management issues where there's a lot of questions about what are best practices and how can we improve what happens. And it's a great pleasure to introduce our first speaker in this section. This is Katie Maslow. She's a scholar in residence at the Institute for Medicine in Washington, D.C., and her primary focus is on care-related issues for older people with dementia, mental illness, and coexisting medical conditions. And she's going to cover the topic of managing patients in hospital settings. Yes, it's left is forward, right is back.
Thank you. I'm happy to be here to be talking about this topic. It's going to be a jolt for you to go from the amyloid and tau and prevention into care. But I think that the data that Ken just showed gives us a reason to believe that even if we have a cure for any of these conditions, and even if the prevalent incidence and prevalence decrease, there are going to be millions and millions of people to take care of. So these management care issues are important. Uh-oh. Thank you. Okay, so this is what I'm going to talk about this afternoon. I'm going to talk about the number and proportion of hospital patients who have Alzheimer's and other dementias, their reasons for being admitted to the hospital, and who makes the decisions. Then I'm going to talk about factors that limit intentional management of hospital care for people with dementia. By intentional management, I mean that the practices, the care are intended for people with dementia and delivered to people with dementia. So I'm not saying that good care isn't provided in general, but that I'm going to be saying it's seldom intentionally managed good care. I'm going to talk about some of the adverse in-hospital and post-hospital outcomes and what's been tried to increase intentional management and improve outcomes. So how many people with dementia go into hospitals? The available data show that people with Alzheimer's and other dementias are 2 to 3 times more likely to be hospitalized than other older adults. So a large number of individuals with Alzheimer's and other dementias go into the hospital every year, some more than once. People with Alzheimer's and other dementias are more likely than other older people to have potentially preventable hospitalizations. The definition of potentially preventable hospitalizations in people with dementia is sort of questionable in my opinion, and maybe we'll have a chance to talk about that later, but this is data based on the usual way that potentially preventable hospitalizations are measured in government data now. If you think from the perspective of hospitals about these data that I'm talking about, the data mean that up to a quarter of hospital patients, of any hospital's patients, are people with, older patients, are people with dementia. So this is a substantial proportion of hospital patients, of older hospital patients. And I think that that is something that can be used perhaps to push forward some of the ideas that have been tested for improving care for people with dementia. There are a lot of problems with the data that I've presented and that you could find anyplace else. So most people with dementia in the United States still don't have a diagnosis. They haven't had a formal diagnostic evaluation, and they have no diagnosis in their medical record. So when they go into the hospital, no diagnosis goes with them. In addition, the data that we have and that I just was using doesn't include a large proportion of older people in the United States. So a quarter of older people in the United States are now enrolled in Medicare Advantage programs, the HMO and other capitated care programs, and their utilization data aren't available. So we're missing those, and we're missing in the data that I just presented anyone under 65 with dementia. I think still that the data about the proportion of people with dementia versus people without dementia that are hospitalized, and the data about the large proportion of older hospital patients who have dementia, those data are probably close to right, and the truth is probably just as likely to be a higher number as it is to be a lower number. So why are they hospitalized? Most people with dementia are not hospitalized, at least explicitly, for their dementia. They're hospitalized for a variety of other coexisting conditions that are common in people with dementia, in all older people in our country. At least explicitly, that's what they're hospitalized for. I think that it's likely that most people with dementia are not hospitalized for specific Alzheimer's or dementia symptoms, even though some people think that that's why they're hospitalized. Also, you've probably heard about what's been called social admissions, what's now more frequently called social economic kind of admissions. And those admissions are for people who need 3 days in the hospital so that they can get Medicare coverage in the nursing home when they're discharged, at least for a little while. And then in this category, some people say that people with dementia are admitted to the hospital to give their caregiver a break. So I think that if we look at the sort of back up from those reasons and try to think about what they're saying, I think it's probably right to say that people with Alzheimer's and other dementias are often admitted to the hospital because of difficulties in managing their coexisting medical conditions in a person with cognitive impairment, because of perceived medical crises, perceived behavioral crises, perceived by the family caregiver often, and because of a lack of other options. So who makes these decisions about people going into the hospital, people with dementia? Of course, in the end, the decision is made by a physician, but the decisions are often made in a complicated process. And if you look at the literature about this, you see that family caregivers have a role, and other service providers, long-term care, home and community-based service providers have a role. So the decision is not just the decision of a physician. It's probably true that in the case of planned hospitalizations, the physician has a role, the family probably has a role, maybe the person also has a role in making the decisions. In the case of unplanned admissions. And these are, I'm talking about admissions to the hospital through the emergency department. I don't know if you're aware of this, but in the U.S., the latest data show that half of all hospital admissions are now through the ED. So a lot of people are going into the hospital through the ED. In 2008, which is the latest data that I'm aware of, 30% of the 1.9 million older fee-for-service Medicare beneficiaries with dementia who had an ED visit were sent into the hospital. That's complicated, and it reflects those data problems that I was talking about earlier. But basically, about a third of people who go from home or nursing home or assisted living into the emergency department then go on into the hospital. If you look at it from the other perspective, that is the perspective of the hospital, about 40% of people with dementia who end up in the hospital came in through the ED. So if you have ever taken a person with dementia into the ED, or if you have you see patients who with dementia who have been through the ED, I think that you can imagine what the implications are of for those individuals, what they've already been through in terms of time, in terms of an agitating environment for a person with dementia, treatments that they don't understand, a lot of questions they don't understand. This affects how people are as they come into a hospital unit. In all of these decisions, that is the decisions that are decisions for planned hospitalizations and unplanned hospitalizations, I think that a major question is whether the person's dementia was considered as part of thinking through, is this hospitalization a good idea? And I think that you'll see, perhaps that's obvious to you why that's an important question. I think you'll see more as I present to you what data show about what happens to people with Alzheimer's and other dementias in the hospital. But I think that it is rare, probably, in our society. I don't know any data that speak to this question. Maybe some of you do. But I think it's rare in our society that this is explicitly considered. Is this hospitalization a good idea, considering that the person has dementia? Or is there some other way to go? Should we make a different decision? Also, it's important to consider the hospitalizations of people with dementia in the context of what seems to be a lot of transitions for people with dementia. I don't know how many of you have seen Chris Callahan's article about transitional care, but he's followed 4,000 or so patients from 2001 to 2008, I think it is, and watching their transitions from one setting to another. So he looked at hospital to home, home to hospital, nursing home to hospital to home, also home health care, and found that at first, people with dementia have more transitions than other older people. People with dementia have more transitions in their last year of life, in their last 90 days of life, and in their last 3 days of life. I'm not going to talk about that because Mary Beth Gallagher, who will talk next, is going to talk about care in the end of life for people with dementia. But so hospitalizations are happening for people with dementia who may go into the hospital from any of those other places, go out, not necessarily back to where they came in from, and keep moving, churning between places. So we have a lot of hospitalizations for various reasons. We have decisions being made by a lot of different people, all in the context of this pretty high level of care transitions. And I think that we have in hospitals now a confluence of factors that results in less lack of intentional management for hospital patients with dementia. So the factors, I think, are that cause this lack of intentional management. One is the patients, the people with dementia, are not identified. It's hard to do intentional management if you don't know which of your patients have dementia. So that's a factor. They're not identified, as I said earlier, because they haven't been diagnosed. Their diagnosis didn't go with them to the hospital. Various factors, and most hospitals at this point don't do any sort of screening or testing or even asking about pre-existing dementia. So a second factor, hospital staff. I'm talking here about nurses and aides who do most of the hands-on care, technicians, people who deliver the food, those kinds of people who actually are hands-on care for the person, have very, very little, if any, training about dementia or dementia care. There's also in hospitals now, I think, a pretty strong belief that that's not really a necessary aspect of training for these people, that it's not a high priority training area. Hospitals are busy places, as you know. They have a lot of other pressures. They are told constantly what's high priority from outside and from inside. So I've heard this idea many times. Maybe some of you have also heard it. So this is what I think is a common belief of staff in hospitals. And they may say this, if you push about dementia care, we need better dementia care in the hospital. They'll say, the patient had Alzheimer's or dementia when he or she came in the hospital and will have the condition when he or she leaves. We can't do anything about the Alzheimer's or dementia. We have to treat the admitting diagnosis or condition. Why focus on Alzheimer's or dementia? So we have a sort of a lack of focus there. I think the bottom line right now in most hospitals in the United States, so there are, of course, exceptions, and I don't know about other countries, but I think in the United States there are some staff members in a few hospitals who are explicitly and intentionally focusing on improving management and outcomes for people with Alzheimer's and other dementias. But this focus is not widespread or generally endorsed. So this topic, this issue, is not getting a lot of attention. So what happens in the hospital? What I'm going to show you now is 4 slides of adverse events, adverse outcomes of care in the hospital while the person's still there. These are from the literature, so what they show is greater likelihood of all of these conditions in people with dementia compared with other older people. Some of the ratios are 1 or 2, and some are 5 or 6, but at any rate, all of these occur more often in hospital patients with dementia than in other hospital patients. You can see easily what they are. I'm sure some of you have thought about these problems. I'm sure that you can imagine why they are problems. Just an example or two: falls. So people with dementia often have other neurological deficits that make them unsteady on their feet. But more so in the hospital, they didn't hear or understand the nurse saying, "Don't get out of the bed," or call if you need assistance. So they have more falls. In terms of untreated pain, they don't communicate well about their pain often, or on the other side, sometimes their calling out about pain is ignored because staff has a perception that this is a person that's confused and what they're saying isn't factual. So delirium, falls, new incontinence, people who become incontinent who were not when they came in the hospital, untreated pain, agitation. This is, you can picture, as I said before, coming through the ED, but the same thing, perhaps to a lesser extent, goes on in the hospital. The person doesn't know what's happening, doesn't know where they are. I'm making generalizations now. Of course, some people do, but everything is new. The treatments are difficult, not understood, and so on. Inadequate nutrition, inadequate fluid intake, functional decline. There are no data, I haven't seen data for the inadequate nutrition, but I have heard many stories, and perhaps some of you have also, about hospital patients with dementia who don't eat because they don't recognize the tray, they don't recognize that it's food, or someone didn't take the cover off of it and they don't know how to eat it. Other examples, new indwelling urinary catheters, pressure ulcers, physical restraints that may occur because of the agitation and perhaps aggressive behaviors. It may also occur because the person's getting out of bed and the staff is worried they're going to fall. And new feeding tubes are very often put in the hospital. So here's an example that's every hospital doesn't want to have happen. This was at the University of Pittsburgh Hospital in 2008. An 89-year-old woman died on the roof of the hospital in December, and the investigations afterwards, of course. So she had dementia, and she wandered unnoticed from her room through a fire exit that was only 5 feet from her room, up 2 flights of stairs, out through the boiler room and an unlocked door, and onto the roof, and died in the night from too cold. It was too cold. So this is a disaster for the hospital and for everyone. We don't know how often it happens, but I don't know if you've heard other stories. I certainly have. But there are other things that are happening that are dangerous like this with respect to wandering, where you wonder about staff not understanding, here's the patient that might wander, and we better do something about that. So nurses often talk about situations where someone from the floor has been taken down on a gurney or in a chair to have a test and left there, and then they're not there when someone comes out to do the test, or the person with dementia decided that she wanted to go home and just got dressed and walked out and was on her way home with no one being aware of it. So these things are things that happen in the hospital. I think hospitals don't want this kind of thing to be noticed very much, and so we don't have good data on it, and I don't know how often it happens, but it does happen. Hospital staff have difficulty if asked. I don't know if you know this niche program at NYU. It's a program for nurses, so it's done a lot of interviewing of nurses about care for older people. But when nurses talk about care for people with dementia, they often mention that, say that they have difficulty coping with the person's confusion, their behavioral symptoms. They have difficulty communicating with the person. Of course they do. And they say they have difficulty dealing with families. We can talk about this more later if we have time, but you can imagine a family seeing the worsening agitation of the person and thinking, how am I going to take him or her home, and what's going to happen next, and pressing the nurse or the aide about these kinds of issues or complaining. And then, of course, when people come into the hospital, other siblings than the main caregiver come home, and they have a different idea, and they pester, and soon a lot of people are pestering. Many hospital staff people say families are the biggest problem they have. And then, of course, is this question which faces physicians often and is of concern to everyone, which is making treatment decisions in the hospital, sometimes fast, when the person isn't capable of participating, and you don't really know whether the person was capable a few weeks ago, might be capable pretty soon, or has been cognitively impaired for a long time and is simply not capable. So, post-hospital outcomes. Families say often that the person went to the hospital, came out worse, and never got better. And there are a lot of studies that show that they're probably right. There are a lot of studies showing that people with dementia, and this is compared with other older people who have been hospitalized, are more likely to be functionally impaired after the hospitalization and at various intervals. I've seen studies up to a year, so they're more likely to be functionally impaired than other older people. They're more likely to go to a nursing home. They're more likely to be in the nursing home over time. And there are also some new data now showing that people with dementia who are discharged from the hospital are more likely to be readmitted to the hospital. So if you think about all these negative outcomes that I've mentioned, and this large group of people that need care, and as Ken said, the risk is decreased, but still we have this large number of people. It seems to me that this setting, hospital setting, is a good place to make care better, and the outcomes, these negative outcomes, even if people have great care at home in an assisted living facility or in a nursing home, if they go into the hospital and they have this kind of negative short-term and long-term effects, people with dementia have difficulty relearning skills. It seems to me that this is a challenge for us to improve care in these settings. So what's been tried? I'm going to tell you what's going to sound like, I think, a lot of things have been tried. These things have been tried in a single hospital, on one floor of the hospital. They don't keep going. So I'm going to tell you the ideas that have been tried, but it's not a lot. It's not a lot of things. So identification and documentation of cognitive impairment and dementia. There are several studies that have tried to identify people with possible dementia as they come into the hospital. The data from these studies are pretty staggering. As older people who are sick or have had medications, as you know, may be cognitively impaired for that reason. So your screening at hospital admission is likely to be picking up people who have all different levels of MCI and dementia, and people who have delirium, either on top of the dementia or alone. But anyway, one study that was done in Indianapolis found that 42% of older people who came into the hospital had cognitive impairment, and of those, 20% had a diagnosis. So 80% had nothing in their record that told the staff that this was a problem, and that's difficult. But at any rate, people have tried screening. It works. But there's an interesting study also from Indianapolis where this clinical decision support study for physicians. So physicians were notified of the data about their patients, and it was recommended that they ask for a geriatric consult on those patients, and that they decrease the use of Foley catheter, physical restraints, and anticholinergic drugs. So that message went out, and nothing happened. There was no change, no statistically significant change in the use of those treatments or the request for geriatric consults. So we can't know whether those steps would be effective or not, but we can know how hard it is to make change in a hospital. So there have been various efforts for staff training. There's an interesting project that has been led by Jim Galvin, who's at NYU, the NYU ADRC now, and staff from the Alzheimer's Association chapter in St. Louis, where they put together a training program for nurses and anyone else who was willing to come. They gave the program many times in 4 hospitals in the St. Louis area. You can see there were positive effects in terms of the people who came reporting that they had learned something. Very few people responded to a later request about, are you doing any of these things? And the article about this again tells you how difficult it is to get a hospital to let you take their staff off the floor for training, and how difficult it is then to deal with what is high turnover in many hospitals. People need training all the time, and again, you're trying to take people off the floor in order to have training. Other things that have been tried, hospital grand rounds, training that's specifically for nursing staff. There's a series of what's called Try This. This is coming from the niche program at NYU, and you can see what the topics are. These are 2-page sort of tip sheets for mostly intended for nurses about these particular problems. So how to work with families, how to assess various problems and then intervene, communication, wandering, and so on. They're free, they're downloadable, there are videos that go with all of them, and there are, the American Journal of Nursing has articles about each of them. Some hospitals, and I've listed the 3 that I can think of, have hired a person to be a dementia care specialist, usually on 1 or 2 units of the hospital. It works. Hospital staff learn to use that person to ask questions. Only one of these programs continues, as far as I know. You may know of other situations where this occurs, but again, it's not a high priority, even though it's used. And we have no outcome data to say that there are improvements in outcomes. There has been in the U.S. 1 dementia-specific unit in a hospital in New York City, in Cabrini Hospital. It had only 8 beds. The information that's available about it provides just startling and exciting ideas about what can happen if you do things right in the hospital. And it was closed as the hospital, new management came in to the hospital. It was closed. It's worth reading, though, for those what happened. Other things that I've seen reference to, wandering screening tool, wandering gowns, put the people that you know have dementia in a certain color gown, so if they walk out the front door, someone might notice. Have armbands for people with dementia. Have forms that families can fill out and put up on the wall in the person's room that tell the staff, what is this person like? What are they used to? What do they like to eat? What do they say? What happens if they're in pain? Those kinds of things. Activity boxes, things that people can fiddle with if they are, as they're sitting in their bed. Information meetings and support groups for families, printable and online information for families. And then some of these other things. For do not hospitalize orders, they're not dementia specific, and I only know one study. You may know others. In 2001, there was a study of nursing home patients with dementia who had, looking at those who had do not hospitalize orders, and nationally it was 7%. So that's not going to make much difference in terms of people being hospitalized. You'll hear about art therapy, I think, later on today. That's good. Care transitions. As you know, care transitions are a major, or maybe you don't know, a major focus of the federal government and policy people in terms of the costs associated and the implications for hospital discharge policies and whether errors that are occurring in transitions are causing these readmissions. So most of the care transition interventions that have been developed and are being used are not specific for dementia. One is Mary Naylor at University of Pennsylvania conducted a study where she compared the use of an advanced practice nurse who meets the person and family in the hospital and then takes them through about 2 months after the person goes home, comparing that to all kinds of training and that you could provide for nurses in the hospital to manage dementia better. And the data from that study are good. It's just been published. Good reduction in 30-day readmissions and reduction in 90-day readmissions, longer time to readmission or death for the person with dementia who received that help from the advanced practice nurse. So that's exciting, interesting, and in an area that's very much the focus of attention in the federal government, at least. Okay, some projects, many dementia care projects measure hospitalization as an outcome. So if you find an intervention for dementia that can reduce hospitalizations, then you can get it into the Journal of the American Medical Association or anywhere else that you would like to have it. Not very many studies have done that, have succeeded. So they're using hospitalization as an outcome measure, but they're not doing anything to actually reduce the hospitalizations. Very few interventions that I'm aware of have tried at all explicitly to reduce hospitalizations. I think that this is a sort of a touchy area. Why do you want to reduce them? What does it say about the value of the person? So I would say that it says the person has high value and you don't want them to be unnecessarily hospitalized. But that's a long message in a complicated and emotionally charged area. So I think that this is something that we need more discussion about, and we need to begin to look at the possibility of both working with families and working with physicians and other people who send individuals into the emergency department or directly to the hospital to try to bring in this question of, is this a good idea for this person with dementia? For the person's health and welfare, is it a good idea? So right now, I would say, and I hope you've heard me say, many people with dementia are hospitalized. They constitute a substantial proportion of all older hospital patients. There are various factors that interfere with intentional management of their care in hospitals. Many of them experience serious in-hospital adverse events and serious negative post-hospital outcomes. Some of the approaches that have been tried have failed. Some have succeeded, at least in part, but very few, if any, are being continued. So I'm interested in any questions or any ideas that you might have about this. And maybe we want to wait till later? Do you want to wait till later? Okay.